A very good day, my dear postgraduate students. Thanks for your overwhelming response to the liver biopsy 1. Now, we shall continue with the liver biopsy chapter 2. Always I used to say, think of the subheadings. The subheadings will take you to the answer. Also, you find that there should be a refreshment of the previous chapter before we start anything anew. In this, we shall be talking about the mode of reporting, architecture, patterns, various hepatitis, any special strain, which I have already covered, cellular changes, necrosis, apoptosis, pigments and neoplasm. Also, I shall be touching upon the IHC and immunofluorescence, just to highlight where these exactly fall. As a continuation of our last session, here I see a CT scan wherein there is a diffuse enlargement of the liver. There is a hepatomegaly, a portal edema, as well as an ascites. I think these arrows are supposed to show it. And there is also a thickening of the bile duct and the gallbladder. And it is said that multiphasic CECT or MR will be mandatory for a better picturization. The top differential diagnosis in a case of a diffuse hepatomegaly can be steatosis or steatohepatosis. After that, there is a cirrhosis and a shrinkage. Any form of hepatitis, be it infective or autoimmune. Hepatic injury because of toxins and passive congestion of the liver. So this is a reasonable list of differential diagnosis we should have in mind. And when we talk about the patterns of liver injury, it is not a traumatic injury, but the injury that can happen because of the various etiologies. Can be lobular, portal, there can be a fatty change, biliary cholestasis or obstruction, necrosis, inclusions and pigmentations, granuloma, vasculitis, infiltration of the sinusoids, as well as the tumors. So this should always be borne in mind. A checklist should be running at the back of our mind. When it comes to bile stasis, I hope you people are able to appreciate the golden brown pigment of the bile. It can be hepatic, wherein leave alone these blotches. Even in the others, I am able to find a diffuse powdery precipitate of bile. So this usually happens in any hepatic disorders. Remember, there is a hepatic jaundice per se. Also, there can be bile lakes, which happens in any form of an obstruction or a biliary cirrhosis. So the way to distinguish between the two. Obviously, there is some amount of fibrosis and inflammation, which I can make out in the background. So the patterns of distribution of the pigments or the precipitates are also important. The granulomatous hepatitis we had seen in the last one, and in this there is a kind of a lipogranuloma that is over there. It can be alcohol related or non-alcoholic liver disease. A lot of these differentials are given there. It is only a recapitulation. And also viral infections such as cytomegalovirus, Coxiella should be borne in mind, immunological R.A.T.S and another infective leishmaniasis. We are made wise not by the recollection of our past, but by the responsibility for our future. Amazing saying. Maybe the world's most sarcastic person, but then I really adore him. George Bernard Shaw. I told you about the mode of reporting of a hepatic biopsy, a liver biopsy. Even now, we were contemplating reporting a liver transplant, wherein many such things were lacking. First and foremost will be the clinical and the laboratory findings. Because many a diagnosis cannot be purely on what we see in a small strip of slide that is hardly about 1 centimeter. Biochemical findings. What are the various enzymatic changes that you people can see? Microbiological and immunological. Whether there is any particular antibody that is specifically increased. The radiological picture, I had given you quite a few examples of diffuse as well as a locular enlargement. And after all this, what is the provisional, the clinical diagnosis that the clinician makes? These are of paramount importance. And when we come to the sample itself, whether the lesion is represented in the sample, whether you are able to see the unaffected, so-called unaffected liver also. Is it inflammatory? And what is the distribution? What is the type? It is periportal or it is perivenular? Do you find a granulome? Is there any hint of an autoimmune, plasma cells, etc.? Or a storage, large, bizarre cells with vacuolated cytoplasm? Or a spongiform appearance? Degenerative disorder, diffuse, multifocal. It can be metastasis or it can be even a primary hepatocellular carcinoma. Fibrosis, early fibrosis. And what can I do with the reticulin stain, etc. The bile and the bile pigments I mentioned, neoplasm. And sometimes we do get tumor-like lesions, pileosis hepatis, a classical example. And how do I go with the grading and the staging? And finally, what is the diagnosis? This should be the mode of report that we should have. Of course, each institute has got its own. This is something that I had reconstructed from the references we had seen. As I told you, the inflammation can be mainly periportal. And even in the periportal region, it can be periductal. So I find that there is a cluster of these lymphocytes that are seen around the bile ducts, which are showing some kind of a degeneration, and there is also some kind of an inflammation of the ductal epithelium. As a reaction to this, there can be a proliferation and also there can be a dysplasia of the ducts, which should be borne in mind. Many of these adhesions, look at the mitotic figure over here, you find that there is a stimulation, then there is a proliferation, there is an adhesion, and I find multiple glandular spaces which can very well mimic a neoplasm. The ground glass appearance, we are all quite well versed with it. I find that it is quite powdery, the ground glass appearance. Sometimes the nucleus also has got a ground glass appearance. These could be because of the Dane particles, the inclusion that you see in a case of hepatitis. There is also fine hydropic change that I can make out in the remaining hepatocytes. The bridging fibrosis, which I shall be explaining. The mesenteric is quite useful in delineating the extent of the inflammation and the fibrosis along. Steatosis, a very common term that is overused or sometimes underused. And as I told you, in a case of a transplantation, there has to be lesser than 30%. Less than 10% is ideally and readily accepted by the transplant surgeon. It can be microvesicular. Multiple small vacuoles are seen, just like a hydropic change, and the nucleus is almost centrally placed, not displaced. Early stages of fatty liver, it can happen in pregnancy, any degeneration as such, and diseases that are related to the fatty liver. This by itself is only an outcome and not the disease itself. Mitochondrial DNA depletion. Ornithine can be used for genetic purposes. Wilson's disease, herpes virus, infection. And some of these can go in for macrovesicular, whereas others are purely macrovesicular. Alcoholic, non-alcoholic liver disease, metabolic, such as diabetes, hypothyroidism, fibrosis, Wilson's disease again, malnutrition, petrochemical, carbon tetrachloride poisoning, Ray's syndrome because of aspirin. These are some of the classical ones. Only thing we people should be aware of the distribution of the fatty chain. When it is going to be because of hypoxia, etc., it will be more perivenular, whereas in the case of aspirin, etc., it can be more periportal. Between the left and the right, I would like you people to kindly trace the evolution. Initially, I find that the inflammation, as I had been mentioning, is confined to the perivenular region, particularly in a case of stagnation or hypoxia. Later on, there can be other instances which are periportal, particularly in a case of immunological or non-immunological infective diseases. All said and done, I find that there is the plate. Between the hepatic lobules, there is no line of demarcation at all. And I find that there can be a fine destruction and then a regeneration by nucleated cells, etc., somewhat called the interface hepatitis, wherein I see the lymphocytes, quite diffuse. Here again, I would like you people to kindly appreciate the vacuolation and the ground glass appearance. All said and done, this is the portal triad, this is the central vein, absolutely no relation to each other. And there is again a triad over here. There is something that is evolving without a central vein. So there is an effacement of the architecture. So there is a kind of fibrosis. So how do all this happen is your reading. As I had been mentioning earlier, initially there can be a perivenular. There is a central vein around which there can be the spurs of the fibrous tissue, beautiful ones, which can be made out either by the mesons trichrome or by any other connective tissue stain. Trichrome is perhaps the best. And later on, there can be a periportal, as I had mentioned earlier. So it is a periportal region. And the spurs of this fibrous tissue are seen making inroads into the hepatic parenchyma. And later on, I find that there is a bridging inflammation replaced by fibrosis called the bridging fibrosis. These patterns we people should be having in mind. And remember the adequacy, there has to be at least about 10 portal triads, and even if they are incomplete, it is said it is adequate. Because part of it might not be represented, part of it would have been destroyed by the pathological process. So that can be a confluent one. Again, the liver is a very deceptive organ. So, but for this, I will not realize that there has been a destruction, there has been a regeneration at all. So there is a vein and then there is a portal region. There is an inflammation that is bridging. Sometimes it can be acute, as in the case of any of the transplants, etc. This is a beautiful schematic picture. Fine. I would like you people to simply draw this. Look at this one. The red line as a bridging, necrosis and fibrosis. It can be from the central vein to the central vein of another lobule, or from the portal triad to another, or from the portal triad towards the central vein. So this is called the bridging necrosis or the bridging fibrosis. Of course, these terms I still prefer to the recent ones of interface hepatitis and fibrosis. So this is the classical interface. I do not know where it has started, but obviously I find that there is something over here and then other parenchyma that are being very deceptively infiltrated by the inflammatory cells, which are, however, more prominent in the case of a periportal inflammation in this region. You should be systematic when you analyze a liver. It is a small biopsy. Nevertheless, identify the major patterns, the architecture. What is an architecture? I shall be telling you. Whether it is from portal tract to central vein. And what about the various structures of the portal tract itself? the artery, the vein, the bile ducts, etc. What are the inflammatory cells? Is it an acute inflammation, chronic inflammation, or plasma cells indicate an autoimmune disorder? And the hepatic globules, hepatocytes itself, whether they have got any inclusions. Sinusoids, do not forget. It can be a ballooning degeneration and then there can be a narrowing. Or sometimes there may be no sinusoids, etc., as in the trabecular case of a hepatocellular carcinoma. Central vein for the inflammation and other pathology also should be borne in mind. So be very systematic. You start from one region and go towards another. This is what we had been seeing earlier. Now look at this one, a fantastic design, which is called an architecture. What is an architecture basically? It is the relationship of one structure to another. That is called an architecture. Architect is not an engineer. So he imagines certain things. So it is a beautiful imagination. I do not know what it depicts, but then it is fantastic. Here, I am able to see the liver. So as I told you, there are so many structures which are absent. What am I blabbering about? See. So you have got the central vein, the portal triad, and then there is an intervening zone 2. So there are the sinusoidal spaces and the hepatocytes which are radiating and somewhat branching. And there is a kind of a pattern that is there. Relationship of one part of a tissue to another is called the architecture, which is totally effaced over here. Sometimes, instead of a large chunk of the tissue, we find that there can be an individual cell-by-cell death and apoptosis or a piecemeal necrosis. Look at this one. This is a band of hepatocytes over here, and one is being devoured and it is being replaced by an inflammatory cell. Sometimes another one can be over here, and the central vein or portal triad in the vicinity. So if it is not very clear, look at this. Again, there is a fine granular hepatocyte, wherein I find that there are two structures which are eosinophilic without nucleus, and there is not much of an inflammation. So it is definitely apoptotic body. So the councilman bodies, no, which we say are classical of hepatitis, is in fact the prototype of the yellow fever, and later on only comes the viral hepatitis. The ground glass appearance again, and this is yet another one, though out of context. I would like you people to kindly appreciate the beautiful magenta colored inclusions that you see in a case of alpha-1 antitrypsin deficiency. The PAS being used to demonstrate the alpha-1 antitrypsin deficiency and the pathology thereof. These inclusions could otherwise have been missed. The use of special states, it continues over here, and the deposition of iron, etc. The Pearl's Prussian blue, you people are very familiar with it in your bone marrow as well as in the liver and elsewhere. It is also a slide for you in the exam as an exercise. In HNA, of course, I find a brown, a golden brown or a dark brown color, which can again be because of lipofuscin, or sometimes it can be even a melanin, or sometimes it can be the iron itself. Iron I'm able to demonstrate by means of the Pearl's Prussian blue, and if it is going to be melanin, don't say Mason's Fontana or Doppler reaction, because the pigment is already there. I have to remove it and I use a melanin bleach, ascorbic acid or formic acid or a potassium permanganate. Use these, they will bleach the melanin. The third one, of course, is the lipofuscin, which is the aging pigment that can be demonstrated by means of the Small stain. So the golden brown pigment, that is a differential diagnosis. The malarious hyaline, classically we have seen. Alcoholic liver disease, you find because of the intermediate filaments, you find that there is an accumulation. Earlier it was thought to be just degenerating mitochondria itself. So amorphous, irregular, within the hepatocytes, I am able to find the hyaline structures, which can again be positive in a case of Wilson's disease, in a biliary cirrhosis, or in a case of alcoholic hepatitis, hepatocellular carcinoma, multiple things, which we will have to correlate with the histological, clinical, and other findings. The steatohepatitis, which is quite clear over here, than the hydropic change or the microvesicular fatty change we had seen elsewhere. So there is also an early amount of fibrosis that has started. So when it comes to the grading of fibrosis, this you people can make use of. I would like you to kindly memorize it. Memorize it. It is not very difficult. The histological staging. There are about 4 stages of it. In one, there is no fibrosis at all. One is mild fibrosis, and there is an extension, periportal extension. There are different ways of grading it. Ludwig is one, IASL is one, and Metaware is one. And these all measure the degree of fibrosis and give us a concrete idea about it. So this one I would like you people to kindly memorize. For example, there can be a severe fibrosis in IACL, Ludwig, it can be numerous bridges or septae, and then Metaware, it mainly confined to the portal to central. And finally, all of them lead to a cirrhosis. And after cirrhosis, the drama is over. I stop drinking after developing a cirrhosis, which is not of much use. The role of liver biopsy in diagnosing metabolic diseases. This particular table I took from elsewhere. I would like you people to kindly see the list. Lysosomal storage diseases, fibrosis we have already seen. And what are the stains which can be used? Mitochondrial diseases can be supplemented by electron microscopy if required. And enzymology, for which only the liver enzymes are more reliable. Rhodamin stain. Forget this N over here. So it is used for demonstrating copper in a case of Wilson's disease. And this is the reference over here. Malignancy. Whenever I talk about malignancy, there are 3 things to remember in the liver. One can be a hepatocellular carcinoma, 2 a cholangiocarcinoma, and third one will be a metastatic carcinoma. Hepatoblastoma occurs in children, that is a totally different one. And the way of differentiating between these two, there are some histological differences which are given. For example, even if it is a trabecular form, both can have trabecular form. There will be broad trabecular in a case of hepatocellular carcinoma. It will be quite narrow in a case of cholangiocarcinoma. Bile lakes may be present in cholangiocarcinoma. Individual cells bile stasis can be present in hepatocellular carcinoma. And of course, you can have a Mallory's hyaline and other structure in a case of hepatocellular carcinoma. A well-formed glandular one. Look at this one. There is very slender trabeculae, hardly about 2 cells thick. Whereas in this case, it will be much broader. And the variants of hepatocellular carcinoma, including the fibrolamellar variant, which has got a better prognosis, the complete list, you people can. Coming to the immunohistochemistry, what is the difference between a hepatocellular and a cholangiocarcinoma? These are the markers. List of markers. Again, I would like you people to kindly memorize. Alpha fetoprotein, carcinoembryonic antigen, HepAR1, and glycopan, cytokeratin, etc. 8, 7, 19, and 20. So these are all essential. And metastatic adenocarcinoma, cytokeratin 20 is supposed to be positive, negative in a case of primary hepatocellular carcinoma. Cholangiocarcinoma, cytokeratin 7 and 90. So this particular list, there is a reference over here. I would like you people to kindly go to it and read. But please do memorize the list of markers. What are the diagnoses in this case? Forget the reference. It is one of the Wikipedias as such. I find that there are large cells which are ballooned out. The nucleus is central. If I look very carefully, there are multiple small vacuoles, but then even otherwise, the cell itself is being replaced by vacuolation. So it indicates a storage disorder. How do I identify it? What is the history behind it? What is the enzymology, etc. should be there. And perhaps the PAS with diastase can help me fetch the diagnosis. This is the alpha-1 antitrypsin. This is courtesy level firm. This is again a beautiful reference, almost a mini atlas, which will give us a lot of pictures. Hats off to them for the wonderful contributions. The IHC markers, the list continues. So between the hepatocellular cholangiocarcinoma we have seen. But then when it is epithelioid or a hemangioendothelioma, I find hemangioendothelioma fact rate related antigen will be positive. Angiomyolipoma, it can be HMB45 or smooth muscle. And other metastatic tumors, these will be the markers. Kindly go through this patiently and try to repeatedly memorize them. Not at one stroke. You will be able to. And so also this. What is the cell? What is the antibody that is used? Mallory dunk bodies that I had shown you can be demonstrated by means of ubiquity. Intake open, metastasis. Sometimes we do see tumors, but then they say the primary is not there. Can I jump into a diagnosis of hepatocellular carcinoma? Okay. Or putting it another way, when they are not sure of the primary, but they say metastasis, can I give a diagnosis of a metastasis? These are all million-dollar questions which the pathologist faces. It is very easy to say a metastasis and finally realize there is no primary tumor elsewhere. Look at this one, nasopharyngeal metastasis. That is positive for HEPAR1 and CK7, immunostain in chronic cholecystitis. So it is the bile ductal epithelium that is taking up the stain. Ballooning degeneration, not a tumor as such, but then the hepatocytes are undergoing a ballooning degeneration, which has been demonstrated by diaminobenzene staining. Using this the antibody over here, thanks to ResearchGate. As I told you, that can be the immunofluorescence. Any of the autoimmune disorders means females, 9:1 ratio. It will be applicable generally. So there is a female predominance or preponderance, absence of any other serological marker, which is not there. And then the immunoglobulins can be the anti-nuclear antibody or the anti-smooth muscle antibody, etc. can be there. Anti-mitochondrial antibodies also can be present. And the treatment will be by immunosuppression therapy and steroids. So what will happen is this is being easily treated provided we give the correct diagnosis, and therefore you people should have an idea about it and the panel of fluorescent markers that are being used. Again, clinical history is of paramount importance. So these are certain diseases or disorders. And what do I find in the slide? There can be a periportal globules, alpha-1 antitrypsin deficiency. Amyloid, we all know, acellular, extracellular deposits. And glycogen storage, swollen cells, hemochromatosis, golden brown, ground glass, hepatocyte, pseudo ground glass, immunosuppression, mitochondrial injury, microvesicular steatosis. Sickle cell, quite rare, and within the sinusoid there can be sickle cells. This can be kept as an exam slide, not in the liver very commonly, but in the spleen. It is one of the common exam slides. Just have it in mind. Wilson's disease, a macronodular cirrhosis. So in this one, the transplant rejection is another one that is to be added to my list. It can be either in the perivenular region. So it is here. Around the central vein, there is a series of the inflammation. And whenever, if it is going to be an acute rejection, I will be able to see the neutrophils. And otherwise, I will be able to find some lymphocytes as well as the plasma cells. So this is the bile duct and this is the portal vein over here around which I am finding the inflammatory infiltrate extending to interface. And there is a hydropic degeneration in the hepatocytes. Maybe microvesicular fatty changes also present. Transplant. Here I find that there is almost a total destruction of the hepatic globules. And there is a dense cluster of these lymphocytes and a few plasma cells. Reactive biliary epithelium can be seen. And This is BANF scheme is one method by which we can grade this rejection. Post-transplant also, look at the fatty change over here. In fact, we are supposed to assess the pre-transplant liver, and the fatty change should not be more than 30%, less than 10% will be ideal. But sometimes even after a transplant, it can develop a fatty change, which is happening in this particular case. Look at this. And the best way to demonstrate it again by means of a frozen section and an oil red rose stain. To summarize, the liver biopsy, it is a century-old procedure. My professor of medicine used to say, the single best investigation in a case of liver disorders will be the needle biopsy. Traditional gold standard, challenged by other non-invasive techniques nowadays. And it has been recommended for years to come. That is the summary of the authors over here. And this person, Michael S. Torbenson, has done a tremendous work, is utmost simple, and he has given all the credit to the 4 authors of the previous editions. But he by himself has done something fantastic. If you people can lay your hands on this, I would like you people to kindly go through. Of course, I understand your pressure as a student of post-graduation. You will not be having much time. And these are the other things. These are some of the references. Liver Fellow Network is an atlas which we can all go to. Biopsies. Tissue is the issue. I think it's a nice quote. The interpretation of biopsies, it is more of the experience that stands behind a person than the knowledge within the head. Thank you.